All right, so I should be recording. All right, I think everything's looking good. So, let's see. Hi, Miss. Can you only treat Hep C with PEG interferon or other interferon works too? Sorry, quick question on the last test. Typically, you would not just use interferon by itself. You'd typically see that used with ribavirin. But as I kind of we were talking about the newer drug classes, that those are kind of going by the wayside a bit, mainly because of the newer therapies being so much better tolerated and being able to achieve an actual virologic cure. So you're definitely seeing a lot more of that. All right. So anyway, so this I'm gonna go ahead and get started on our urology topics. Since this isn't like a in-person, face-to-face kind of thing. I think that I don't know how long things will go. Like I may talk a little faster or slower depending on the situation. But yeah, let's go ahead and get started with our urology topic. So first off, we'll be talking about erectile dysfunction and some of the medications that we can use to manage that. And so basically, what do we determine to be like the definition of erectile dysfunction? Essentially is when, a patient's unable to achieve an erection that's suitable for intercourse, and typically over the period of time, say 3 months or so. It's important from not only just like from a, diagnosis standpoint, but also from like a pharmacologic standpoint to understand sort of the difference between like true erectile dysfunction versus something like infertility versus having a decreased libido, because from my standpoint, you'll see a lot of medications that can play a role with that. It can actually be inducing a lot of these other things that may not be treated with the same medications you use specifically for erectile dysfunction itself. So we'll kind of get into that and see what our options are. So who we're going to see this in, typically you'll find that the incidence is fairly low in men that are less than 40 years of age, but it's certainly possible, and then will increase with time. We'll see that there's some hormonal changes that occur that can have some bearing on this as well. You'll typically see that there's a lot of concurrent and comorbid conditions that can actually worsen this. So things like having hypertension or any kind of like arterial disease or diabetes causing some peripheral or causing diabetic neuropathies, things like that. And then we'll look at the medications that are commonly linked to erectile dysfunction and other sort of issues in terms of sexual dysfunction in male patients that can be playing a role there as well. So basically, what's the physiology here? How do we achieve erections in the first place? Well, if you were to get the cross section of the penis here, you see there's two corpus cavernosum, and basically when you're in a resting sort of flaccid state, there's a balanced flow here between venous and arterial flow. So sort of blood coming in is equal to blood going out essentially. During interaction, we'll look at some of the neurotransmitters and things that achieve this. You're going to find that there's increased arterial flow, but you're going to have decreased venous flow. So that's why you get that engorgement that occurs, because more blood is flowing in than what's flowing out. So why does that happen? Well, there's several mediators that play a role here, and so these are going to be important in terms of the medications. And there's two main mediators here we're going to find that our medications interact with, and that's cyclic GMP and then there's cyclic AMP. And we'll find that they're going to be stimulated via sort of different mechanisms there. Typically what you're going to find, and this will be kind of the main mechanism we're going to focus on here, is this nitric oxide pathway. And essentially what you're going to find is that with nitric oxide being stimulated, that's going to cause increases in levels of cGMP. And actually this is the same way that our nitrates work, for instance, with angina, right? So nitroglycerin directly provides nitric oxide for this pathway. We'll see where our other medications for ED come into play here. But basically, increases in cyclic GMP will decrease the amount of calcium flowing into that vascular smooth muscle. Less calcium in basically means you're going to have less contraction of that smooth muscle. You get that relaxation, and thus you're going to have more blood flow coming in there. So that's one way. And then we'll also see that acetylcholine or things like prostaglandin E will help to enhance cyclic AMP. This will be important for sort of like the second line sort of set of drugs that we're going to use for erectile dysfunction potentially. So looking at the psychogenic stimuli, right, because typically when erections occur, it's related to typically external stimuli that are coming in, and so there's going to be kind of a complex sort of reflex arc that happens here, where basically you're going to see things like the hypothalamus is responsible for helping to integrate sort of external stimuli, and then basically sending that that signal down to the sacral nerve reflex. And once that occurs, that's where you can start to release things like acetylcholine as part of these peripheral cholinergic nerves. And so this is actually kind of interesting because you can already see where some medications are going to be playing a role here in terms of like causing erectile dysfunction. So for instance, you'll see that dopamine exerts pro-erectogenic effect. So presumably if you were to block dopamine, you'd see the opposite action, right? So if you had something like an antipsychotic on board, say your patient was on haloperidol, that was blocking dopamine, then potentially you could end up seeing that they could have erectile dysfunction because they're just lacking that dopamine, right? There's that. And also things like alpha-2 stimulation will inhibit erections. So for instance, if I had a drug like clonidine on board or guanfacine or something like that, that could definitely cause some issues there. Let's see. Anyone that's having issue with sound, can you guys all hear me? Okay. Oh, sorry about that. The video I post up later should be totally fine because I'm recording it directly from my computer. So sorry about that. If you missed something, just ask me to repeat it. That's totally fine. So anyway, so that's kind of how we actually have the erection develop. And then in terms of like detumescence, or going back to that flaccid state, this is where norepinephrine is going to be playing a role here. And so that makes sense as well, since that norepi will basically cause stimulation of those alpha-1 receptors, should cause contraction of that vascular smooth muscle, and thus will decrease arterial flow basically back down to what it should have been beforehand. This will also cause some venous outflow increases as well, unless you get back to that typical balance you saw in the first place in kind of the resting sort of state. So let's look at some other effects here as well. Things like testosterone are going to be playing a big role here. This stimulates libido. And we're also going to see that it's not just testosterone, but we've talked about this before in terms of the actions of dihydrotestosterone. If you recall, 5-alpha reductase is the enzyme that converts testosterone over into DHT, which is a stronger androgen by its actions and just testosterone itself. And so we'll also find this is playing a role in terms of like BPH. When we talk about prostatic hypertrophy, we'll look at this a little bit later on there as well. Keep in mind, testosterone itself does get converted over into estradiol. You guys remember which enzyme does that by any chance? Hopefully, because you just got tested on it yesterday. See if anyone can type it in. Yes, there you go. Yes, very good, Christian. Yeah, so like aromatase is the enzyme that will do that, and that's where you can get some effects of kind of feminization, the gynecomastia, things like that. But the important thing here with testosterone is that you have to make sure that you're interpreting levels appropriately. There's issues in terms of like patients can have erectile dysfunction and have normal levels, or maybe you want to look at things like free levels, and it can help you out in terms of like what the actual free fraction of testosterone is. And keep in mind, this is different. You may have low levels of testosterone causing you to have a decreased libido, but that's different than erectile dysfunction. Not wanting to have sex is different from unable to physiologically being able to have sex, right? So we'll look at that as well in terms of like medications that could be interacting here. So in terms of pathophys, why this occurs, a lot of it could be related to things like vascular injury over time, things like arteriosclerosis, neurologic issues. We'll find that diabetes is a big one that does this frequently due to kind of chronic nerve damage that occurs. But certainly if you had someone like a spinal cord injury or stroke or something, that could play a role. And certainly hormonal effects, right? So just natural aging where you're having decreased testosterone, if you maybe have a testicular removal due to cancer or something. And then also remember that balance between dopamine and prolactin. So if you're having decreased dopamine activity, you would end up having increased prolactin activity. So that balance there makes sense why you would end up seeing hyperprolactinemia causing an overall decrease in dopamine activity, thus leading to erectile dysfunction like we talked about before. Frequently though, we just don't know the reason why. It just kind of naturally occurs on its own. But there is also things like psychogenic erectile dysfunction, where you may have, say for instance, concomitant mental health issues like depression or anxiety, all of which could be playing a role here. And again, it could be multifactorial. It could be a lot of things happening all at the same time. So keep in mind, for patients, they need to be in the proper sort of frame of mind, so for instance, if they're having dementia, if they have pretty progressive Alzheimer's, they may not really be in the mental state necessary in order to process that external stimuli in order to have an erection. So you want to be able to delineate and say, okay, what's the actual issue at play here in terms of how we're actually going to treat this, because you may find that certain medications may not be appropriate depending on the situation. So I want to focus on this because this is a common thing you can sort of identify in your patient's medication list in terms of things that are likely to cause erectile dysfunction and things that we can maybe either switch off on their regimens or maybe discontinue altogether. So in terms of things that are most common, we're going to see anticholinergics are a big one. That includes things like your antihistamine drugs. It includes a lot of your antipsychotics like phenothiazines and TCAs as well. And if we talked about this during behavioral health, that we know that and I apologize if you hear a baby screaming in the background. They did not sleep well last night, and so they're a little cranky today, but that's okay. So talking about antidepressants, we know that things like TCAs and SSRIs tend to be sort of the worst offenders in terms of causing erectile dysfunction, but certainly things like bupropion tend to be a little bit better from that standpoint. So, if you had a patient who's on amitriptyline for depression and they're complaining about maybe not being able to have sex with their partner and that's causing further stress, something like bupropion may be appropriate, right? But looking at your dopamine antagonists, certainly this makes sense as well, as having less dopamine activity could lead to less pro-erectogenic effects. So certainly a lot of your antipsychotic drugs and even things like metoclopramide or Reglan could all be playing a role here. So not only that, but if you have increased prolactin levels, that also decreases testosterone production, which can also exacerbate the problem. In terms of hormonal things that can affect this, so anytime you're having drugs that are decreasing overall testosterone activity could be playing a role. So like estrogens being supplemented, anti-androgens. So for instance, if we had someone on something like spironolactone, that can cause an overall decrease in testosterone activity. Any of these things can be playing a role here, such that you have less testosterone basically available to mediate that sort of that libido there. The other really common one you're going to run into that a lot of patients may not really think about are going to be CNS depressants, right? So patients who maybe have benzodiazepines or opioids on board, if your mental status is depressed to the point where you can't process external stimuli, then nothing's going to happen. Essentially, that reflex arc is never stimulated. But you'll see this a lot with patients who maybe have consumed large doses of ethanol or if they're on anticonvulsants. So basically, look at their mental status, make sure that's clear and that they can actually process that external stimuli before you kind of jump the gun and try to treat it with other types of medications. Let's see. So this is another common group of drugs that are going to be doing this as well. So anything that decreases blood flow, and this can be things like your central sympatholytics. So things like clonidine can do this. Beta blockers can do this. Certainly alpha blockers, things like prazosin or doxazosin, and diuretics, right? So for the most part, you're going to find that patients tend to do better with this if they're on an ACE inhibitor, an ARB, or potentially calcium channel blocker. Those are less likely to cause erectile dysfunction as compared to things like your beta blockers. And there's a lot of miscellaneous agents as well. We'll talk about finasteride and dutasteride later on as being drugs that actually block 5-alpha reductase. This will be important in our talks on BPH a little bit later on. And then things even like lithium, MAOIs. There's a lot of kind of miscellaneous agents that could also be playing a role. So certainly, if you're ever not sure, just look it up, and you can pretty easily find that in the adverse reactions listing. So in terms of your diagnosis, obviously you want to make sure you're getting a thorough history, make sure you're getting a current up-to-date medication list in terms of what the patient's actually taking right now, and look at those concomitant disease states and whatnot. Testosterone levels may be helpful, but it does require that sort of that correct interpretation of it, which can be a little tricky there. So our goals for these patients here are basically going to be to try to improve the quantity and quality of suitable erections for them, making sure they have reasonable expectations of what they should expect to occur. This is not like a drug. If it's the patients are having issues with their partner due to things like depression, like this is not going to fix that, right? So you got to look at the underlying issues and try to treat those at the same time. We also want to make sure these are patients with legitimate complaints. So does anyone think that these medications could be abused potentially? I don't think so. So anyway, yeah, they absolutely can be. So this is typically, and what's actually kind of funny, I'll talk about this later, but our medications that we typically use for erectile dysfunction, we actually keep those locked up in our vault. A lot of times we treat them as controlled substances because they do have a high tendency to have patients, or not patients, but healthcare workers actually will divert them. So basically you have young men who probably don't have any issues with erectile dysfunction, maybe using this for, say, performance enhancement. So this is why we actually keep pretty tight control on things like our Viagra and whatnot to make sure that, we're not going to be seeing any of it walk off potentially to someone who doesn't really need it. So make sure patients actually have a legitimate complaint for it. And then we're going to look for things that are well tolerated and also reasonable cost for patients. Because this is more of a sort of lifestyle set of medications, you may find insurances don't want to cover large amounts of it, or they may only cover a limited supply. So for instance, I know some patients, they would only get covered for, say, like 3 pills a month or 9 pills a month or something like that for some of these agents here. So we'll look more into details on that and kind of see how we're going to use these. So obviously correct any kind of underlying issues that patients may have in terms of like their diabetes and their smoking and all of that. And then obviously address any kind of mental health issues if they are present. And then we'll look at the actual things we can do to treat this. So I'll very briefly talk about the surgical options and the vacuum erection devices, but we'll mainly focus on the pharmacologic therapy here for our patients. So ideally, you'd want these treatments to have pretty fast onset, be convenient, efficacious, and discreet is also something a lot of patients would like to have. If you can just pop a pill, it's much easier than getting out an entire device in order to have sex with their partner. So typically what you're going to find is we're going to go with things that are kind of least invasive and kind of go more invasive as we go forward. So this is the typical flow kind of diagram of how we would manage these patients here. So we kind of already talked about managing risk factors and getting rid of medications that can contribute. We'll get into it, but we'll talk about the phosphodiesterase inhibitors. And these are going to be things like your Viagras and whatnot. These are going to be kind of your first stop for majority of patients here. There'll be some that are going to have contraindications, which we'll get into, but most patients will start here, right? If it works for them, that's great. If not, then you can look at other options here. So say, for instance, if they could not receive a phosphodiesterase inhibitor, we'll get into things like using vacuum devices, and then we'll also look at some intracavernosal or intraurethral options as well. This is a little more invasive, and so we like to hold off on using these until we've kind of shown that they're not going to really be appropriate candidates for any other options here. And that's still not effective, then we'll look at some surgical options as well, which we'll talk about very briefly. So in terms of the vacuum erection devices, these tend to be actually pretty effective, but they're not very discreet. And that's going to be something that a lot of patients may not be super into, mainly because, it's just a lot of, it's a lot more invasive or a lot more cumbersome than just taking a pill, for instance, right? But it's good for patients who may have high-risk cardiovascular histories or something like that may not be really good candidates for phosphodiesterase inhibitors here. You also want to think about things like onset. So for instance, here, this device will work within 3 to 20 minutes. So they'd want to use that pretty close to the actual time of intercourse versus if you have someone who's going to be taking a tablet, you might imagine that onset's going to be a little slower. And we'll look at that when we get into the oral options. But timing is going to be important in terms of how you educate these patients here. And you can use these in combination with other therapies, so and sometimes they'll try using them prior to surgical options. So this is what I want to get into more in depth are going to be our actual medications here. So we had the phosphodiesterase inhibitors. And we talked about that cyclic GMP pathway in terms of how it can cause erections to occur. So basically what you find is that nitric oxide gets released during the sexual stimulation of the patient. You're going to find this will increase levels of cyclic GMP, which causes less calcium to flow into that vascular smooth muscle, and then you're going to have relaxation of that smooth muscle. So normally what happens if you have no pharmacologic intervention is that cGMP actually gets broken down by the enzyme phosphodiesterase. This is how you keep that balance there between the two in terms of not having too much cGMP. Well, what we can do is try to tip that scale in the favor of the patient and achieving an erection by basically inhibiting that enzyme phosphodiesterase. So either by giving something like sildenafil or vardenafil, they will inhibit that breakdown, and thus you have more cGMP, thus you have more vascular smooth muscle relaxation, thus more blood flow in, and hopefully you have that erection that can occur. So we have 4 main agents in this category, including sildenafil, which is the typical Viagra, like the first one out there on the market. You have vardenafil, tadalafil, and then avanafil. Basically, these are analogs of cyclic GMP that kind of trick the enzyme into trying to metabolize them, and then basically inhibit that enzyme such that it can't break down normal cyclic GMP. Now, one thing you're going to see here is that there are different isoenzymes of phosphodiesterase that are out there. So, for instance, the one that we care about in terms of treating erectile dysfunction is going to be PDE5. Okay, when we get into some of the side effects for other agents, we're going to see that there are different ones, and depending on their activity at those different isoenzymes, different side effects can occur. And so that'll be really important to know which might be appropriate for certain types of patients. Okay, so PDE5 is the main one we care about in terms of treating erectile dysfunction, but we'll see it's important for other things. Now, I've probably mentioned this before, but we actually carry things like tadalafil and sildenafil at Nemours. Anyone know why we would carry drugs like that at a children's hospital? Say that again. I couldn't quite hear you. As I see for heart problem, hypertension. Yeah, so it's actually, pulmonary hypertension. There you go. Yes, absolutely right. So pulmonary hypertension. So what you actually find is that PDE5 is also highly expressed there in the lungs as well, in that pulmonary vasculature. So we actually use that for a lot of kids who have congenital heart defects, who may have issues with pulmonary hypertension. We actually use it for that specifically. So, so again, different indications, but the mechanism is exactly the same as you'll see there. So anyway, from this slide, don't memorize all of the numbers on here by any means, but some of the things I want you to look at is going to be the different activity at some of these different phosphodiesterase enzymes here, in terms of which ones are going to work where, and I'll go into more details on that going forward. But we're also going to see things like, the half-life is going to be different between these different agents. You can see here things like tadalafil have quite a long half-life, and that'll be important in terms of your dosing and duration of action. So for instance, some of these agents are only going to work for maybe 4 to 5 hours, which is probably appropriate for most kind of single instances of intercourse. But you have one here that work up to 36 hours and may be good for, say, a couple days worth of therapy, essentially, right? So basically you take it on Friday evening and it kind of covers you throughout the whole weekend, essentially. Which ones we're picking may be dependent on things like how we're using them. Something like tadalafil is also really good for those pulmonary hypertension kids because it does provide nice long acting coverage throughout the day. So we'll find some different options there. So this is a good one you kind of refer back to in terms of kind of the differences and similarities between the different ones we have here. So, as I mentioned, phosphodiesterase inhibitors should be sort of our first-line therapy, especially in those kind of younger patients. It's also pretty discreet, easy to pop a pill, no problem there. But the ones we pick are going to be based on the selection, and that'll be dictated based on adverse effects, the onset, the duration, and then the overall cost of treatment as well. And I remember when I was a young lad and I was working as an intern at CVS. It was like between my first and second year of pharmacy school, I think. I remember I would have guys that would come in. This was like when Viagra was like kind of first out, and it was still brand name only. And you'd have guys that would come up, and they're usually like kind of like dressed all to the nines. It was a Friday evening, come by, and they just pick up one pill, pay cash for it because their insurance weren't covered and all of that. So that was a big cost to them. And so it was one of those things where, if you can find something that can be, manageable for your patient, depending on what their situation is, that can be really, really helpful there. But you'll find most patients do respond pretty well to this. If they don't, it's most likely because they have some kind of comorbid condition that may make it more of an issue. So maybe they have dementia or Alzheimer's or diabetes or something like that is further complicating the issue. So typically we'll see that if they have a therapeutic failure, some of it may be related to things like food interactions in terms of like, how do fatty meals affect this? Does it slow down the onset of action when they maybe didn't schedule out, when intercourse might be happening for them potentially? Overall, we'll try to have them take about 5 to 8 doses or so before we see how it's working for them, and we may try to titrate up as needed. Definitely educate to avoid excess alcohol because that can lead to, decreased response to external stimuli, and they may think that the drug wasn't working when really it's just they had this concomitant CNS depression that maybe made it more difficult for them to achieve an erection in the first place. The other thing to note here is that you typically want to avoid these drugs in healthy patients, which I mentioned were kind of a risk for like a diversion sort of situation, but also anyone who may have issues with, say, blood flow, say something like sickle cell disease or leukemia or something like that, because you may find there's sort of the kind of sludging of the blood that can occur in those situations may lead to things like priapism that can occur there, which is a urologic emergency. Does anyone? So that's why they always mention, like in the commercials, if you ever heard commercials like if you have an erection for more than 4 hours, call your doctor. That's related to that priapism. Overall, you end up finding you have decreased flow of oxygen to the tissue, and it can eventually start to have tissue necrosis, and gangrene can occur, which is not great for your patients, right? Does anyone know how we treat priapism? No. So basically, there's a couple of different options. So say they come into the ER and they're complaining of I see phenylephrine. That's actually going to be one of the drugs they'll try. Yeah. Basically, there's two options. You either can basically do manual drainage. They can basically use a needle and try to drain the blood out to occur. And if that is not effective, then they'll frequently do some sort of vasoconstrictor. And so they'll do a really dilute solution of phenylephrine and inject that into the cavernosa, and that will also help out as well. So a couple of different options there. But if we can avoid this, that's always going to be beneficial. Okay, so here's where I get into the different isoenzymes of phosphodiesterase. So 6 and 11 are going to be the other big ones we'll talk about in terms of side effects. So we mentioned PDE5, find that in the lungs, find that in the being helpful for causing erections. PDE6 is going to be found in the rods and cones of the eye. So if you inhibit PDE6 here, you can end up seeing things like blurred vision and then cyanopsia. Anyone know what that means? We talked about xanthopsia before being sort of like a yellowing of the vision with like digoxin. Yes, blue vision. There you go. Yeah, so they get kind of like a bluing of the vision there a little bit. So, which is kind of funny because Viagra was always known as like the little blue pill, but it can also make your vision go blue because you'll find that sildenafil actually is going to be the most potent one at affecting PDE6. So this will be the most likely one to cause visual disturbances will be sildenafil, less likely so with the other ones here. The other big thing you're going to find is that PD11 is actually localized to striated muscle. And so this is a reason why you may find myalgias that can occur with these agents here. And specifically with tadalafil has the greatest affinity. Actually, something interesting, we actually had a study going for a period of time over at Nemours. We're actually trying out tadalafil in patients with like Duchenne's muscular dystrophy to see if that actually helped out with like increasing blood flow to the muscles, things like that. Ultimately didn't end up working, but it's interesting how we're using that particular drug mainly because we do know that it had specificity for working there in that muscle. So anyway, so looking at the onset of the drugs here, you're going to find that sildenafil and vardenafil typically are going to have slower onset, especially if it's consumed within 2 hours of food. And you kind of think about a typical date night, if you're eating dinner, you're kind of thinking about the time frame, how things are going to happen there. You want to make sure that your patients are timing this out so that the drug is ready to work when the patient's ready to have intercourse, right? So typically about a 1 to 2 hour onset. If you're taking it 5 minutes beforehand and they're like, the drug didn't work, well, you didn't give it time to really work, right? Duration is going to be longest with tadalafil, but tadalafil also has the slowest onset, so that's the other thing you want to watch out for that one there. These can be metabolized by CYP3A4, so you do want to watch out to see if there's any interacting drugs there and make sure you're decreasing your dose of the phosphodiesterase inhibitor if necessary. And then sildenafil and tadalafil may be renally adjusted. Doesn't come too often, but it's one thing you might want to look out for in your patients. So adverse effects, these are fairly common, and if you think about how the drugs are working in terms of causing vasodilation, it makes sense why they would cause things like headaches, right? You can see some of that cerebral blood vessels dilating, causing pressure, leading to headaches. You can see why facial flushing would occur because you're getting vasodilation in some of those blood vessels in the face. Dyspepsia is also another one you may see due to the lower esophageal sphincter being affected as well. That can get a little bit looser and cause regurgitation of stomach contents. And then nasal congestion and dizziness are another set of common ones you'll see there as well. All of it's related to that same mechanism of vasodilation, essentially. You can see some drops in blood pressure. This will be asymptomatic in most patients, but it'll be more noticeable if they're on, say, multiple antihypertensives, say they're on clonidine and a beta blocker, for instance, or, and this will be a big interaction we'll talk about a little bit later, are going to be nitrates. Or you may actually really bottom out the patients if you were to combine a phosphodiesterase inhibitor plus a nitrate there. So overall, I would say use this cautiously or not at all if you have patients that have pretty high risk cardiac histories there. So other things we'll see include things like photophobia, that kind of loss of blue-green color discrimination. That's going to be more likely seen with sildenafil because that one did have the highest specificity for PDE6, but you may find the other agents can do it as well. Most of the time it's reversible. As soon as they just stop taking the medication and it works its way out of the system, it should be fine. But there is this complication here that would be more prompting sort of emergent sort of intervention here. So this non-arteritic anterior ischemic optic neuropathy. And so basically the patient would develop sort of this like unilateral painless blindness that may not be reversible depending on the situation. Now, overall, the reason why this occurs is basically due to this decreased blood flow to the optic nerve. So it stops getting oxygen, stops working, and thus it may lead to permanent damage that may lead to that blindness. And it can even occur at the first dose or may happen after years of use. There's not really a good way to say who's more likely for it to occur. So obviously, if, I think most patients, if they all of a sudden went blind in one eye, they would probably want to go to the ER, but there's another good thing to educate on. It's a low risk, but it's certainly a risk they should know about. So tadalafil is most likely to cause things like back and limb muscle pain, up to about a third of patients there, mainly due to PDE11 inhibition. And then vardenafil can cause QT prolongation, so you would want to watch out for that. If it's combined with other medications, it can affect the QT. Priapism is pretty rare if used appropriately in patients with actual erectile dysfunction, but is more likely to occur if you're using like pretty high doses or if you have other, say, erectogenic medications on board, which we'll go over a few of those coming up in a few minutes. So this is the big one. You always want to make sure that patients who are receiving nitrates do not take phosphodiesterase inhibitors, or at least they are separating them out such that they're not taking the two together, because you will see some pretty significant drops in blood pressure, which can lead to things like syncope, can lead to MI, things like that. And if you think about it, like, why would a patient take a nitrate and a phosphodiesterase inhibitor at the same time? Anyone can think why that would occur? ER situation, perhaps, atherosclerosis, like an emergency, old person at home, MI. Yeah, so think about when might, say, someone with angina develop chest pain? Well, probably with exertion. And when might they be exerting themselves? Well, during sex, right? So basically, that's one of the things you might see. They may develop chest pain, mid intercourse, and then they decide to take a nitrate, and that's when they can run into problems, right? Or if, say, for instance, EMS were to arrive and they didn't ask the patient, hey, what medications have you taken or do you take? And they go ahead and they give nitroglycerin. All right, that's where they can see they can bottom out their pressure pretty significantly. So this is why they always want to make sure you ask that sort of question there. And so make sure to at least separate them out by 24 hours and 48 hours in the case of tadalafil. I did see one question was asking about the blue-green color discrimination. That is more common with sildenafil because that does affect PDE6 more specifically, for sure. So anyway, so how would you end up treating those patients if they did develop that pretty significant drop in blood pressure? Just like you would treat really anyone else with drops in blood pressure, you can go ahead and put them in a Trendelenburg position with their feet up and their head down and give them lots of isotonic fluids, and that should bring their pressures back up. So, but again, depending on the type of nitroglycerin they receive, that may be more long or less. The duration will change, right? So if it was just a single 0.4 milligram nitroglycerin sublingual, that would be a lot shorter acting than something like they took their isosorbide mononitrate and it's like working for 8 hours or something. So that's the one big interaction you should definitely know about. And then the 3A4 inhibitors, make sure if they did have concomitant 3A4 inhibitors on board, you go ahead and start out at a lower dose with their phosphodiesterase inhibitors there. So as an alternative to a phosphodiesterase inhibitor, let's say you have someone with a high-risk cardiac history, this may be a good option for them. And so basically we can use alprostadil, which is prostaglandin E1. And so it comes in two main dosage forms here. And again, all of our phosphodiesterase inhibitors have been oral dosage forms. This one either is going to be an intracavernosal injection, so it'll be either Caverject or Edex. And then there's an intraurethral insert. So the brand name is Muse, which stands for Medicated Urethral System for Erection. So sometimes they kind of stretch things a little bit to get the acronyms they want. But overall, instead of having to work through the nitric oxide pathway, we can go ahead and work on the adenylate cyclase pathway and try to increase levels of cyclic AMP. And overall, you're going to end up finding that you'll have that increased or decreases the intracellular calcium and causes the same effect of less smooth muscle relaxation or more smooth muscle relaxation than you would see otherwise. So instead of going through nitric oxide, this one goes through cyclic AMP. And so this is good for patients who may have issues with their nitric oxide pathway. If they have diabetes or a prostatectomy, something like that, this is a good alternative there. Now, in terms of where it's going to be inserted, this is going to be pretty locally acting. That's also the big benefit there, is the fact that it's not going to be working systemically. Let's see, did you say people abuse PDE inhibitors for performance enhancement? Yes, that would be the bedroom performance enhancement we were referring to there. I don't think they're going to play baseball any better or anything, but certainly they may use it for their more social dalliances, we should say. Anywho, so looking at this, you're going to find that the intracavernosal tends to be more efficacious than intraurethral, which makes pretty good sense because you're actually getting the drug directly into the cavernosa itself, where it's going to have 100% bioavailability there. And so we used to use other agents like things like atropine and phentolamine, but we actually found that they had a higher risk for priapism, so we kind of avoid these now and just use alprostadil. And it's really effective, up to 90% efficacious, but you're going to find that it does have some changes in terms of this duration of action and whatnot. Overall, this is going to work fairly very quick. It's a very quick onset of action, but a short duration of action. So between 12 and 44 minutes or so. So basically, this would be something that you'd want to use, say, 10-15 minutes prior to intercourse, and then it's only going to last for a short period of time, which should be long enough for most individuals for their purposes there. Keep in mind, if the issue is more kind of psychogenic erectile dysfunction, they tend to respond better at lower doses than, say, if it was more of a vascular issue for those patients. And you don't really see much tolerance to this, so they can use it kind of for as long as they need to. Typically, patients won't stick with this because it's not nearly as convenient as something like a tablet. So either that, or they are needle phobic, or maybe they just lose interest as time goes on, especially if they're older, or the cost of therapy tends to be higher than you would see for something like a sildenafil or something like that. So a lot of reasons why patients may just kind of lose interest and not really care anymore. And so you're not worried about systemic effects with intracavernosal injection. You're really not, because again, the alprostadil itself has a really short duration of action, and it's just working right there in the penile tissue. It really doesn't get spread systemically all that well, and so you have very little systemic side effects to worry about, which is nice. And in fact, we use alprostadil too, especially in premature neonates once they're born. We go ahead and we see that being given to keep the PDA open, or keep the ductus arteriosus open. We use alprostadil to do that because it kind of has a similar action, but that has to be given via continuous drip IV because it has such a short duration of action. But anyway, won't that hurt very bad? I imagine, yes, it does probably hurt, but again, you're going to be using pretty high gauge needles. That should help to limit that, and then we'll see technique is going to be another big thing there. So really, you'll just inject it into one cavernosa. Let them know not to expect a very long duration of action, definitely not more than an hour or so, mainly because that's such a short half-life here. And they'll typically do 5-10 minutes before intercourse there. And you can see here, using a pretty short, pretty high gauge needle. Obviously, remember that the higher the gauge means the smaller the needle itself is. And then obviously you want to look at aseptic technique. You don't want to end up getting secondary skin infections or something because they were didn't wash their hands and use alcohol swabs and all of that. So obviously, local pain at the injection site will be the most common thing you'll run into. This typically gets better with time as their injection technique gets better, but you can see things like fibrotic areas and plaques that can develop over time, and they typically will just say stop using it until it kind of resolves on its own. Priapism is a possibility. It's probably a little bit higher risk than you would see with the phosphodiesterase inhibitors, but still relatively rare. So in terms of intraurethral injection, so obviously there's basically it's a device you'll have that can be inserted into the urethra. It's a tiny suppository that basically will be left there that will then melt and then get absorbed there through the urethra. There is risk for things like urethral damage, especially if the insertion is not done appropriately, and so you may see things like stricture that can happen over time. So this may not be good for patients who may already have issues with like BPH or anything that causes obstruction of urine flow from the urethra, so things like that to think about. So, and then there's penile prosthetics. These kind of come in two flavors, either malleable or inflatable. These work pretty well for patients, but obviously it's more invasive. Typically we've tried other things before they get to this not overall infection is probably the most common adverse effect, but not not a big risk as long as appropriate precautions are taken. This is kind of interesting. I was talking to one student who was on rotation at a urology office, and he actually came back, and I was like, oh, how was it? And they were like, yeah, all we did was these penile prosthetics day in and day out. It's all we did all day long. And I was like, really? Like, they didn't want, I didn't think a lot of people want to go to surgery. And said, no, there's a lot of older guys, getting up in their 70s and 80s. They just don't want to care anymore. They want to take tablets. They have a high risk cardiac history. They just went straight to the prosthetics. So for some people that works better for them. I say to each their own from that standpoint. So any questions on erectile dysfunction so far? Just wondering, I think there was a huge push for female Viagra, and there were 2 meds approved for female sexual dysfunction. Have you heard of them being used much? I have not heard of them being used much, and I'm struggling to think of what those would be. I'm not sure. I'd have to look that up to see which ones there are out there. But yeah, I'm not sure. I honestly don't see them all too often, or at all, because I don't know what you're talking about. So yes, I've seen 70-year-old male come in for this, become altered mental status, and stay in the hospital for 2 weeks. Yep, that can occur for sure. Let's see. Are there any male OCPs in the works? I think there are. I think they're looking at some ways to do that. I don't think anything is ready for market just yet, but I know that's always been a very popular thing that people are looking for. I will say though that if males get vasectomies, make sure they go ahead and wait the appropriate amount of time before they start having unprotected sex again. I had a technician who had 4 children already, and then her husband got a vasectomy. They didn't wait long enough, and then she got pregnant with twins. So make sure you wait the appropriate amount of time. That's probably the best means of protection there. But let's see. It was flibanserin and bremelanotide. Yeah, it's hard to say for the first time. I just looked up. I don't know anything about it either way. So I'd have to look it up too. I don't know. Maybe we can do that at some point. Okay, any other questions for that? No questions up on the board? All right, so I'll probably have to look that up. I'm kind of interested about that. So, let's see how many slides in I am. About 38 slides in. Yeah, I think I'll go for a little bit longer here. Just make sure we have enough time to cover everything. So, and again, if you guys want to take a break and go use the bathroom, restroom, whatever, feel free to come back whenever. All this is being recorded, so you'll be able to catch back up on anything you miss. All right, so BPH, basically what we're going to see here is this is a pretty common benign neoplasm in most older American men you're going to find. You will see this is nearly ubiquitous in older patients. Again, it's just one of those things where over time it's just going to become worse and worse, as you'll see there. In terms of medical management, you're going to find there's several different pharmacologic agents we have here. Obviously, you could use surgery, but that's not going to be great because you may find some long-standing issues in terms of issues with voiding and whatnot. And obviously, if it's actually deemed true prostatic cancer, yeah, you definitely want to get rid of that. But certainly in terms of pharmacologic management, we do have a lot of options here, and we'll look at how we use these and which ones are better for what. So again, you're going to find that they saw nearly 80% of elderly men develop some degree of BPH there. Not everyone becomes symptomatic, but many of them end up having that enlarged prostate there. And so you will find that many patients do require treatment, although we could do more of kind of a watchful waiting approach depending on how symptomatic those patients are. Anyway, so getting into it, let's see, what does the actual prostate do for us? Well, essentially what it's helping to do is it helps to secrete fluids, especially for the ejaculate. It does provide some secretions there. What's actually kind of interesting as well is that it does provide antibacterial secretion. So it actually has a high zinc content, and that zinc is actually antibacterial. So kind of another reason why male patients tend to be less prone to UTIs is because of that. Not only anatomically we're less likely, but also because of this high zinc concentration and these prostatic secretion. So kind of an interesting thing there. I'll get to your question on the board a little bit later on since it's not to do with this topic. But anyway, so we'll see that the prostate typically will have its first growth spurt at puberty, which makes sense because that's when testosterone starts to become increased in production. And we'll see around 40 or so is when you're going to see kind of a second growth spurt there. So this is important in terms of the different types of tissues here because they have different responses to different sort of either neurotransmitters or hormones. And so the first off here, we see the epithelial or glandular tissue. This is what's producing a lot of the secretions, and these are stimulated by androgens. So testosterone to some degree, but even to a greater degree, DHT. So this would be an important thing for that. And we'll see that as you stimulate that, it's going to get larger due to the anabolic sort of effects that you're going to get from those androgens. There's also the stromal tissue, and these are basically embedded with alpha-1 adrenergic receptors. That means basically you have all these alpha-1 receptors, and if you recall, stimulation of alpha-1 receptors, say like on the blood vessels, what does that do? Yes, absolutely. They cause constriction, and guess what? It does the same thing in the prostate as well. So it actually causes a squeeze of that prostate, which can lead to that impingement of urine outflow. You'll find that essentially there's about a 2-to-1 ratio here between stromal to epithelial tissue there. And there's a capsule that's kind of the fibrous connective tissue and some smooth muscle. This will also contain some adrenergic receptors like alpha-1 receptors. So basically we're going to see that the issue may be more strongly related to either alpha-1 effects, or it could be related to androgen effects, or it could be both at the same time. And so different medications are going to work differently here to see how we're actually going to treat this issue. So we mentioned testosterone gets converted by that 5-alpha reductase enzyme over to DHT, and this is where we see a lot of effects like acne and male growth patterns. It is more potent than testosterone, and this is the big thing that causes prostatic enlargement. So this is one way we're going to be shooting to decrease that enlargement is by decreasing the amount of DHT that we have available to us. We'll also find that estrogen, which we know is going to be a product of androgen metabolism due to aromatase, also can cause some stromal growth in and of itself. So both of these can have stimulatory effects there on the prostate. So this is another kind of good concept to get into in terms of talking about sort of is this more of a stromal issue or more of an epithelial issue here. We'll find that there's static and dynamic factors. And like you might imagine, static factors are kind of just there. They're kind of omnipresent versus dynamic factors may change throughout different states, right, or different parts of the day, things like that. So with static factors, this is mainly going to be related to prostatic enlargement itself that's basically physically blocking the bladder neck, and it obstructs that urinary flow. And this is mainly due to the androgen stimulation. This is the big thing here. Some estrogen stimulation, but a lot of it's going to be the androgen effects here. So a lot of that DHT causing overall the prostate to grow, to be larger kind of all the time, is causing that static factor to impair that urine outflow. The dynamic factors are more going to be related to alpha-1 effects, right? Your sympathetic nervous system is a fast-acting sort of thing where if you stimulate it, it's going to cause constriction there. It can cause sort of brief episodic sort of obstructions of flow. And so things like stress or pain could be things that may trigger this potentially. So again, you may find symptoms are from static factors, dynamic, or it could be a combination of the two there. But especially if they have an enlarged prostate, that's going to be more related most often to those static factors. If they have a normal sized prostate, but they're having issues of impaired urine flow, then that may be more of an issue to those dynamic factors that happen there. So being able to identify which ones the patients are having may clue you in to which medications you want to use for them, okay? So looking at this, we'll find that medications that can potentially cause symptoms of BPH or lead to the effects of BPH include testosterone replacement, because again, we're giving exogenous supplementation to convert more things over into DHT. Adrenergic agonists, this makes sense too. If they are directly stimulating alpha-1 receptors, that would cause squeeze there on the prostate. And then actually our anticholinergics can play a role here as well. And this is more to do with incontinence, which we'll talk about later on. But basically anything anticholinergic is going to cause the detrusor muscle in the bladder to relax and hold on to more urine. And so that may also be exacerbating issues in terms of BPH. So not only do they have impaired flow due to obstruction, but they may also have, they may be retaining more due to that relaxation of that muscle. So looking at the actual symptoms patients will develop in terms of obstructive issues here, you're going to find they have that decreased urinary flow rate. You may find that their bladder emptying is incomplete or pretty slow, which can lead overall to urinary hesitancy and bladder overdistension in some patients, depending on the severity of their issues. Later on, if they have kind of chronic obstructive issues, then they develop these sort of irritative issues. And this is basically due to long-standing bladder neck obstruction. And just like anything, as you're going to find that muscles hypertrophy. So as the bladder muscle tends to hypertrophy, it is less able to store urine as well. And you're going to find that it also becomes really hypersensitive, meaning that even small increases in volume may trigger the urinary response. You need to use the restroom. And so you're going to find that this leads to a lot of frequency and urgency, which can worsen the effects of the actual BPH itself, and also can lead to things like bedwetting, incontinence, nocturia, things like that. And of course, we always worry about older patients getting up in the middle of the night because obviously they're at risk for things like falls and whatnot. So, for symptoms of these patients, they're not always progressive. Some patients may stabilize and may improve without any treatment. So you're going to be watching them for that. And then, as I mentioned, we talk about those irritative symptoms that develop over time. This is that lower urinary tract symptoms. These are the things we're hoping to prevent as time goes on. And this is where treatment is, indicated to try to prevent these kind of long-standing issues from developing. So, again, with complications, you can see things like acute urinary retention can lead to acute renal failure. It's kind of like a post-renal sort of injury. We can see things like hematuria develop. UTIs can be an issue for these patients. And again, you want to think about older patients, altered mental status. Oftentimes, it could be related to infections like UTIs. Could be related back to the BPH, right? Chronic renal failure. All these things can be happening as a result of chronic untreated BPH. So here's a good flow sheet kind of showing you how to manage these patients here. Depending on the degree of symptom severity, we'll see that we can get away with a lot of different options here. So we're mainly going to focus on these patients with the moderate symptoms. Obviously, if it's very mild, you can just watch it potentially, not really do anything. Very severe, then you may talk about things like more invasive surgery or prostatectomies potentially. But let's focus on the moderate symptoms where our medications are going to be playing a role here. And we'll see that depending on comorbid conditions or depending on the size of the prostate or things like that, we can get away with different medication options. And so this is important to identify what's most appropriate for a particular patient. So getting to this, our desired outcomes to try to prevent sort of these lower urinary tract symptoms, things like recurrent UTIs, try to prevent progression or disease complications. Hopefully if we can avoid surgery, that's also beneficial because that will help to avoid some of the complications with surgery that you can see, and then try to find something that's well tolerated and cost effective, obviously. So looking at our pharmacologic therapy we have available to these patients here, we're going to find that in terms of things that relax the prostatic smooth muscle, these are going to be really helpful for the dynamic factors, right? So these are going to be helping to prevent those sort of episodic, sort of acute sort of contractions of that muscle. And so these are where alpha-1 adrenergic, I don't know what an adrenergic is, but an adrenergic antagonist is used most commonly here. Notice that these are not going to decrease the prostate size, has no direct effect on the prostate size, right? If you wanted to decrease the prostate size and help to reduce static factors, that's where your 5-alpha reductase inhibitors are going to come into play. So by causing decreases in the production of DHT, you're going to get a smaller prostate and hopefully having less impingement there on the urethra. And then we're going to find that some agents to help out with relaxing the bladder to allow for better storage. These are going to be better for those irritative symptoms that develop over time, are going to be things like our antimuscarinics. And these will be basically used in more complicated cases later on, and we're going to try to avoid these if we can, and mainly try to focus on treating either the dynamic or the static factors. So looking at our agent selection, this will be determined basically on a case-by-case basis, kind of figuring out based on what their comorbid conditions are, what their other medications are, seeing what's going to work best for them. Typically, the benefits only last for as long as the medication is taken. So for instance, if they are taking something to reduce the size of the prostate and then they stop taking it, well, that prostate may go back right to the size it was beforehand. Typically, we're going to find our alpha-1 antagonists are used as first line, mainly due to the fact that they are pretty fast acting, and they're also going to have fewer side effects. We'll talk about why that is as compared to the 5-alpha reductase inhibitors. But these are going to be used more for patients who have maybe a cardiovascular history, or if they have a really significantly large prostate, that's where you can get more use out of that. Okay. And of course, combination therapy may be warranted. Just depends on the situation, as we'll get into. So patients with erectile dysfunction and BPH, you may find that phosphodiesterase inhibitors can be playing a good role there. If you imagine, phosphodiesterase inhibitors not only work on that arterial smooth muscle, but they can also work on the smooth muscle on the prostate itself. So you may see some relaxation there, and that can be pretty effective. Overall, you're going to find that these are less effective than other agents, but if they have a history of erectile dysfunction and BPH, this may be something useful, right? Patients that have more sort of irritative symptoms, especially if they're more kind of progressive, maybe they haven't been managed well for a long time, anticholinergics can be added on. Just make sure patients don't already have sort of a high post-void residual, because this will worsen that retention there. So that's one thing you want to look out for. Keep in mind, though, that anticholinergics are typically not great for elderly patients because we'll see this is a big one that causes frequently altered mental status, can worsen dementia, things like that. So again, if you can avoid those, I'd probably say do that in those older patients. So getting into the alpha-1 adrenergic antagonists, we have basically 3 generations here. You're going to find that the first generation ones are not used as commonly, and that's mainly because as you block alpha-1 receptors, you're going to see smooth muscle relaxation of the vasculature, which can lead to things like hypotension and a reflex tachycardia, and that frequently causes arrhythmia for these patients. So we don't use the first generation anymore. Since then, we then have the second generation agents, which are a little bit more selective for alpha-1 receptors specifically. And then we're going to find our third generations are actually really nice because they work, basically they're uroselective, meaning they work on this alpha-1A adrenergic receptor. So even getting more specific, work on alpha-1A, and that's actually going to help to limit a lot of the cardiovascular side effects we're going to see. And we'll look, that'll be more apparent as we get into it later on. In terms of efficacy, the second and third generations tend to be equally efficacious. It's just that the third gen ones tend to have fewer side effects. So that's typically why we end up going with the third gens over the second. Keep in mind there's no effect on prostate size here, right? They just affect that constriction of the prostate, don't do anything to the size. So getting into our second generation agents, we've seen these before back when we were talking about antihypertensives. And if you recall, we know that these are not great drugs, especially used as monotherapy for blood pressure because of the reflex increase in the RAS system, and you see that reflex tachycardia and all of that. Orthostatic hypotension is a really big risk with these. So again, you may see these used with, depending on what their comorbid conditions are. If they have hypertension, maybe you can add this on and it may be useful from that standpoint. We will find that something like alfuzosin or uroxetrol tends to be a little bit more specific for the prostate. So this is actually probably a safer one to use for those patients with BPH and maybe high-risk cardiovascular history and whatnot. But the main things to look out for is one is that first dose syncope, mainly related to them not being used to that drop in pressure that you can see with that orthostatic hypotension and resulting dizziness. So again, this may be something you want them to take at nighttime for the first couple of doses, so that way they can kind of sleep through that instead of being up and active in their day and potentially have a fall as a result of that. So typically this is another set of drugs where you're going to start low and go slow, and you can titrate over the course of several weeks. As I mentioned, use this at bedtime. It can be helpful to mitigate some of those effects in terms of having that lower blood pressure. You will find synergism with other antihypertensives. So again, if they're on say an ACE inhibitor for their blood pressure, this is an okay thing to add on if that's not under control. Typically, the shorter acting the agent is, the more likely you are to see big drops in pressure. So prazosin is not great because it requires frequent dosing, and thus it's going to have more likely to have those cardiovascular effects you'd want to watch out for. With doxazosin and alfuzosin, these are going to have longer acting agents, and so they provide sort of a nice steady serum concentration, and that helps to mitigate some of those big drops in pressure you would see with something that was dosed, say, 2 or 3 times a day. And then alfuzosin has the lowest incident of systemic side effects, which I mentioned is probably the safest one of this bunch here. And in fact, it actually doesn't require a whole lot of dose titration as a result of that. So also probably going to be more expensive than something like doxazosin, but it could be beneficial if you had a patient you're really worried about their blood pressure, if you're worried about them having a fall, things like that. So the third generation here is going to be including tamsulosin and then silodosin. I don't see this one used as frequently, mainly due to drug interactions, but certainly tamsulosin is used quite commonly. I will also see this used occasionally for things like kidney stones, mainly because it helps with relaxing the urethra and allowing for easier passages of stones. So you may see it used for that pretty commonly. But basically, you're going to find this gets absorbed best on empty stomach, and we would want to avoid this in patients with sulfa allergies because it could have a cross reaction there. The reason why we like these are mainly because it's going to be pretty selective for the alpha-1A adrenergic receptor, which are mainly found in the prostate. So it's not going to affect a lot of the systemic vasculature because it just doesn't express those particular alpha-1 receptors. So again, almost no hypotension seen here. And for the most part, the biggest symptoms you're going to find include like some mild flu-like symptoms, maybe some nasal congestion as a result of some vasodilation, and anejaculation may be another risk for them. So, looking at that, using phosphodiesterase inhibitors in conjunction with an alpha-1 antagonist can have some synergistic effects there. But you're going to find that the least effect, kind of the safest combo, would be using something like tadalafil and tamsulosin together. Because again, one tamsulosin should not have much effect on blood pressure, and then tadalafil has the longest duration of action, such that it does not have a lot of peak effects. It just has a nice kind of steady serum concentration throughout the day. That makes sense. Okay. So those are the alpha-1 antagonists. Mainly we're talking about they're affecting the dynamic factors. Now let's look at something that help out with the static factors, right? So here we have the 5-alpha reductase inhibitors. The two main ones you'll see are going to be including finasteride and dutasteride. Basically, they're affecting 5-alpha reductase to inhibit it and prevent conversion of testosterone over to DHT. And just to give you some examples here, you find things like DHT levels drop by 80 to 90% in the prostate. Keep in mind, it would be nice if it was just specific for the prostate, but that's not going to be the case, and you'll find that you will find big drops in terms of serum concentrations. This is going to be important in terms of side effects we're going to see for some of these patients here as well, okay? And then dutasteride is actually a non-selective inhibitor, meaning it's going to be even more potent at dropping serum levels of DHT, and so that's one thing to note there. And this is going to be good for patients with enlarged prostates to help out those static factors that are kind of just omnipresent throughout the day, right? Both of these work pretty well as compared to one another, so really the pick is just going to be based off of what insurance covers and things like that. So these are going to be good for patients who I mentioned either having a large prostate, if they cannot tolerate an alpha-1 antagonist for whatever reason, but they could be used in combination. So you could see something like dutasteride and tamsulosin being used at the same time to get better synergy there. Say they have an enlarged prostate and they have those kind of dynamic factors with that alpha-1 agonism there. You'll find that it does reduce prostate size. You may actually find that it helps to decrease prostate cancer risk over time, which makes sense because you don't have as much stimulation on the growth of that tissue. But the difference here is you're going to find that it has much slower onset versus your alpha-1 antagonist, which makes sense because it's basically affecting hormones. We know hormones take time to work because they work down at the site of the actual nucleus and change transcription factors, right? You tend to find higher incidence of sexual side effects, including things like decreased libido, right? And so because of that, we will typically use this as sort of second line for more sexually active patients, mainly because we know this can cause some ejaculatory disorders and decreased libido and all that sort of thing. Let's see. I said a cutout. What did you say? This was good for patient history. If they maybe like a high-risk cardiovascular history, this might be a good option for them. Or if they can't tolerate alpha-1 antagonists, this is good for those type of patients there. So these can be used for the long term. Just remember that if patients start taking something like dutasteride and it shrinks down the prostate, if they stop taking it, it'll go back to its normal size. Now, it's not going to be like an overnight kind of thing where it balloons back out, but it will, over time, go back to sort of the baseline size there. In terms of sexual dysfunction, you're going to find that ejaculation disorders occur mainly due to decreased prostatic secretions, and you may find erectile dysfunction as a result of maybe some inhibition due to the nitric oxide pathway, and then decreased libido overall. So kind of affecting a lot of different features there to lead to the sexual dysfunction. So if it's a relatively younger guy who's still sexually active, this may not be a good option for them potentially. Other things you may see include things like gynecomastia, some nausea, vomiting, whatnot. But this is actually a pregnancy category X. Anyone know why that is, or could you guess? I don't know if it actually passes to women during intercourse at all, but you may actually find that by inhibiting conversion of these hormones, you may have effects on the fetus if, say, a woman was to have contact with it or have any kind of systemic absorption. So this is one of those things where we consider it a hazardous drug, and we have to make sure we're using proper PPE when we're handling it. So for instance, I worked in, early on in my pharmacy career, I worked in a hospital pharmacy where basically any female patient had to wear gloves even if they're touching just the tablets that were in a packaging, because they did not want them to have any accidental exposure potentially. So definitely be very cautious with pregnant women being exposed to this potentially. So using phosphodiesterase inhibitors, again, this is going to be good for patients with concurrent BPH and erectile dysfunction. Keep in mind they may counteract the effects of alpha-1 antagonists because, again, as I mentioned before, alpha-1 antagonists can cause decreased ability to develop an erection, and then 5-alpha reductase inhibitors also decrease libido and all of that. So overall, using a phosphodiesterase inhibitor may counteract some of these effects there and help it make sure your patient can still have a healthy sexual activity with his partner. Again, notice how it's working here. That this can work to help relax that smooth muscle around the prostate and the bladder neck through that same mechanism as it does for the arterial flow into the penis. So most often you're going to find tadalafil is most frequently used, and this is going to be due to a longer duration of action there. Let's see. Would this drug be used in women for anything? Not that I'm aware of. I know I've seen some male patients who were transgender that were transitioning over to female. I've seen them use that to try to drop levels of DHT, but I've never seen a female patient use it for anything specific. So that I'm not aware of anything, but some of you may know something I don't for sure. Let's see. In terms of anticholinergics, these are going to be good for patients who have those irritative symptoms. Again, it kind of mimics like an overactive bladder kind of picture, which we can talk about later. And overall, just make sure you're using lowest doses possible because you do worry about, especially older patients, worry about them and their mental status as a result of the anticholinergics there. So you do want to watch out for that. And then make sure they don't have a whole lot of post-void residual because this may worsen that urinary retention there and lead to some other complications. We'll talk more about that later as we get into the incontinence section. So, and then, surgical intervention is also possible, but there are going to be better for patients who maybe have tried drug therapy, did not work out all that effectively, and this may be the kind of the next step for them. Let's see. Can you repeat the part about how it counteracts the effects of alpha-1 antagonists and 5-alpha reductase inhibitors? Yes. So with the phosphodiesterase inhibitors, right? So if I take an alpha-1 antagonist, like a prazosin or something, that's going to be decreasing. That can lead to issues of regulating blood flow to the penis, which can lead to its own issues of erectile dysfunction. So a lot of antihypertensives are commonly known to lead to ED, essentially. With the 5-alpha reductase inhibitors, they also, as I mentioned before, by decreasing DHT levels or decreasing prostatic secretions, can lead to several different features of erectile dysfunction as well. So by using something like a phosphodiesterase inhibitor, by working through that nitric oxide pathway, the idea is that you try to kind of circumvent those issues and still make it possible for those patients to develop an erection. Again, it may not be perfect, it may not work for every patient, but that's kind of the idea. So if patients did develop issues of erectile dysfunction while on something like dutasteride, it may be reasonable to add on one of those phosphodiesterase inhibitors like tadalafil. And not only that, but it also helps out with the BPH symptoms in and of itself by relaxing some of that prostatic squeeze, but also around the urethra as well. So, okay. So any questions on BPH or erectile dysfunction? Nothing at all. Sure, it feels kind of quick, but it's kind of hard to ask you guys as many questions. I think I'm going to cut it there for today. I think that's probably pretty good for our first meeting. I'll probably be able to get through this fairly quickly. I'm looking at our topic list. Jerry won't take too long, but the majority of our stuff will be on ER and toxicology coming up. But I think it's probably a pretty good place to stop for now. There's one question up on the sticky board that I see. It's the last test question. Would amphotericin B cause pre-renal or intrarenal nephrotoxicity, or intrinsic, we would say? Yeah, that's going to be an intrinsic sort of issue there, mainly because of the fact that amphotericin B can't really tell the difference between fungal cell walls and some of our cell walls. We do have some ergosterol, and so it causes more of an intrinsic sort of issue there. So, any other questions I can answer for you guys? Was this helpful to have the meeting online, sort of, not face-to-face directly, but somewhat? Hope so. Okay, let's see. Okay, so we can't see the test result now. Can we still go to our advisor and ask what we got wrong? I don't think we can go over specific questions unless you failed it, and no one failed the test, which is great. So I don't think there. If you would like, we can talk about kind of more general concepts. So we can maybe schedule something out if you would like. But yeah, overall, just due to the kind of the weird world we live in now, we'll probably it'll be what it is. So, yes, I wish every professor did it live like this. Well, I'm very fortunate I have the ability to do that. I have my lovely wife at home who can watch my kids and hopefully keep them from screaming too much while we do this. But he suggests this to other teachers. Well, everyone does their own thing. So we all at least have one live session before the test. So I think that's going to be really good for everyone to at least get some face-to-face time. But anyway, see, can you refer me to a slide and PP for the OCPs that lower body water? Yes. If you were to go back and look at the ones where it was kind of a slide that was like comparing the different progestins together, you find one that has like low mineralic corticoid effects. So things like drospirenone tend to be pretty good for that because it has anti-mineralic corticoid effects, and so you'd find that it actually does cause decreases in a little bit of body weight and also body water as a result of this kind of diuretic effect. So I don't know the exact slide, but you can go back and see that one. If you have any specific questions about the test, just email me and we can go back to that. Oh, thank you, Sarah, for getting the slide. Anything else I can do for you guys? Or if not, feel free to hop off a call, and I'll see you guys for the next one. I'll put up another announcement giving you a reminder of when that's going to happen. I don't have the date in front of me, but we'll do this again. Oh, it may, but the injury is more so due to the intrinsic issues that it hits there. So, and if anything, having that's what I thought was pretty renal. Yeah, that's not really the big issue because again, like the injury you're seeing there is causing a ton of like electrolyte wasting and inability to really concentrate the urine. So it's really much more of an intrinsic issue. You may have kind of a component of that, but I would definitely say like what's the best answer, and it's definitely going to be the intrinsic sort of effects there. So. All right, well, I guess I'm going to hop off. I will see you guys next time. Have a great day.